Alright, in this phase we're going to perform trach care and if necessary do the trach change at the same time. We're going to kind of go over the procedure so that way we can try to make it effective and to try to avoid any mishaps that can or possibly occur. Once the first thing that we have, usually your baby will be intubated and on the ventilator. They can be very active or sometimes they can be sedated. If they're active, we want to try and restrain them a little bit. We can actually do some sort of thing like placing a blanket underneath their body, pin their arms in the back, or some sort of modality that can keep the baby from moving around. Once the baby is restrained, the only thing we have to prepare for is to put the baby in a position that we can turn and open up the airway and make it effective for us to do our care. We will get a bunch of rows. We can make it. We want to elevate the head high enough so that the head actually falls back and opens up the area. The nurse or the RT will support the circuit with the head, lift the baby up. The other person will turn around and place the row underneath the back. We want to make sure that it's effectively opened up. If you don't have enough rows, repeat the procedure with a larger amount of rows in order to effectively open up the airway. This is not a fast procedure. All we want to try and do is make sure we clean out the site, make sure we're able to inspect it, and make sure that we're able to not lose anything that would cause detriment to the infant. Once we have our supplies all drawn up, we have it laid out. You have your whatever size tracheostomy you have. You want to make sure that you have the next size down plus the size that you have in case you need to change it out, or if during the procedure you have an incident where you actually drop the trach by accident and it gets dirty, you want to be able to grab the other tracheostomy readily available, apply some lubrigel, and insert it. That way you can avoid any other potential problems. Or if the trach is clean and you're doing trach care and for somebody that pops out and we know it's still a clean trach, we have the obturator from the same trach. We can lubricate it, or actually put it into the tracheostomy, lubricate, and then put it back in. So you have both little implements readily available. Those are just a precautionary measure. You will have the lubricant applied to the little patch right there so that way you can make sure that you have it readily available. Do not just turn around and just put it aside. When you need it, you're going to need it right away. You want to be able to get in and get out as quick as possible. So now that we're secured, we have the baby restrained. The nurse's responsibility or the other person's responsibility is to hold the head and hold the trach the entire time period. We're going to turn around and loosen up the straps. Take one out. We'll take the strap off. Some people have a tendency to lifting up the head so we can get the strap up. So we'll lift up the head, get the strap all the way out. We will take the restraint off this other side. Remove it completely. When you inspect it, you want to inspect it, the trach tie to make sure there's no breakdown. If there's any kind of moisture or breakdown, you definitely want to inspect the back. You're going to inspect the back anyway, but you want to pay more attention to wherever the spot may be located, because if you have any kind of breakdown, that has to be addressed. It has to be corrected before you continue. Once we take the other trach towel, you should have a template. Like I said, we spoke earlier that's being prepared. We'll prepare a new template. We'll make sure that it's appropriate in size. And once it's there, take the pre-template that we have that never gets utilized. It's just there for measuring. We'll put that away. We'll get the other trach tie. We'll just slide it back underneath. And once we're laid down, we just leave it there. And then we have to focus in on the area itself. Now that we have a trach here, nurse is going to reposition her hand right up closer to the top part, so that way the other person can turn around and get down toward the bottom of the tracheostomy. Down here we have either a vent, or we can have the Meplex, which is right here. You can use either one depending on what your neonatologist or your ENT specialist requires. And then we'll just turn around and take the A-vent, slide it out. Carefully move it. You want to inspect the A-vent. You want to make sure that if there's any secretions, you want to document the secretions you have, the type, the color, anything else, any foul smelling odors and stuff. And once we've taken it all down, next thing we can do is to do our cleanup. First thing we want to do is clean directly around the stoma. You don't want to use 2x2 for that. You want to use Q-tips with some sterile water. We will take the Q-tip, dip one Q-tip. We're going to lift up the wing, slightly turn it over. You don't want to get far enough out that you actually lose the tracheostomy. She'll be supporting me. She'll be supporting the head so that the head doesn't move around. We lose the tracheostomy. You want to be able to visibly see the trach. You want to take the Q-tip in there and you're going to roll outwardly. Roll away from the patient's skin so that way you don't introduce anything into the stoma. This just goes directly into right next to the stoma, sweeps outward. One-time use, you toss away. You get yourself another one. We're going to get over to the other side. We're going to visualize where we're going to be at. Lift up the stoma, wipe outward, and again sweep out away from the body. So right next to the stoma, clean outward. It's only a small little gap that we're actually cleaning, okay? And then if you have some more Q-tips, we can actually clean on the very top. So we will gently put a little pressure downward so that we can get down below here, swipe outward again. And it's always a swipe away. And down below the tracheostomy, we're gonna lift up, support it, swipe it till we get it completely out. And once we clean those little areas, the area directly around the stomach is clean, it's prepared. You removed any type of debris. Get your 2x2 gauze, that's usually sterile. Don't forget this is a clean procedure, it's not a sterile procedure. And once you get it cleaned up, you can have something like a little saline wipe, or you can have a cup with some sterile water. We can actually duck that in there. Of course, you're wearing gloves. I'm wearing gloves right now. We'll get it in there, squeeze out the excess water. And that's why I like using the 2x2, because you use the sterile gauze. You can take your gauze in here, when it's dry, you just put it in here, squeeze it together with a solution, squeeze the excess out, and now you haven't even touched the gauze. The other way, you're actually squeezing the gauze, whatever inside your glove will actually attach to the gauze, and you can potentially contaminate your patient's stoma area. So once we got this cleaned out, we'll turn around, lift up the area, we'll wipe away, get a new one, another one, we'll grab, lift up the wing, closer to the stoma, right next to it, is adjacent to the cleaned area, not exactly over the stoma itself like the first one, but there's the cleaned area that's adjacent to it, away from there, and swipe always away from the stoma itself. Once you've cleaned up all four sides, make sure you have plenty of gauze to do all the clean. Then you're going to get a new set of gauze, which will be relatively dry. And then you'll turn around and remove any moisture that might have built up. Again, near the stoma, swipe away. You'll pick up the other side, lift, swipe away, so that way you can clear the debris away from the body and not toward the stoma. At this point, if there is a due for a trach change-up, you will prepare your other tracheostomy. You'll dip it, get it all clean. You'll take your syringe. If your tracheostomy has a balloon in it, this particular one does not have a balloon, but you would take it out again. You would attach it to the syringe on the tracheostomy. You would pull it out until all the fluid was out and removed so you can collapse the balloon. You do not want to pull it out with the balloon still attached, because you can do some trauma to the tracheal area. So you pull out all the water, and you want to measure that water. That way you know how much push back into the tracheostomy. Once it's been out, you will turn around, prepare your stoma. You make sure your obturator's in there. You want to dip it inside your gel right there. When the nurse is ready, we'll go ahead and lift out, take out the trach. We would take it out, slide it out in a curvature. We will insert in a curvature fashion toward the tracheostomy, further down. So it goes in and curves backward and downward. And then once it goes inward, and once it goes in and it's set, we'll attach the circuit back onto the tracheostomy. At this point, it's best to go ahead and listen to your patient. You want to make sure that you verify auscultation bilaterally. You want to make sure that you're not within the grooves between the soft tissue and the tracheostomy. That will be detrimental to your patient, of course. And once you confirm that you have breath sounds and it sounds okay, and you want to use a PD cap, you're more than welcome to insert a PD cap to confirm CO2 return. And then from there, you're ready to go. Once we've got it all cleaned up and ready to go, cleaned up, the patient's still restrained, the nurse is still supporting the head. I'm the free one. I'm the one that will have to put everything back together. So at this point, we have Mepilex, or like I said, we could use the 2x2 Advent gauze to put back in there, whichever you decide to utilize. I'm going to go ahead and use the Advent. I'm assuming there's a clean one right here. And when we put it back in there, sometimes people have a hard time lifting these wings up because they're pretty tight. So I make suggestions to people. You get the Advent, fold it in half, put it next to the stoma, and then once you get near the gauze, you can fold it out like a 45-degree angle until you get up there, and then just move it around till you get to the spot that you want. And you want to make sure that you remove any kind of kinks that are inside the gauze. That kink can actually cause a pressure onto the tissue and cause breakdown around that area. Then the nurse is going to lift up the other side slightly. I'm going to get my 2x2 again and slide it around the other. And it's going to look like a small bow tie right around the face. And then we'll have our gauze in there. Verify that it's nice and smooth. Make sure that you have no breakdown. Once it's in there, it's good to go. This time, you're continuing mid-late, and you want every once in a while just looking to press on, make sure the patient's okay. Make sure you monitor your vital signs, make sure you're doing well. Once we're good, and then we'll turn around and take our trach ties. We can turn around and insert our one groove. Some people have a tendency using hemostats because it's easier for it to get the tips of it, but you want the tip of your trach tie to lift up and over the gauze. You want to tack it down so that your A-band gauze is underneath your trach tie. Then we will get the following part. Lift up, lift in, insert the trach tie, lift up and over. Again, make sure that the A-band gauze is underneath the trach tie. You're going to want to place one finger underneath, one finger's width underneath the trach tie. If it can fit down there, then it should be adequate so that we don't have any kind of damage to the back of the throat. Once we're completed there, we're going to listen to breath sounds to make sure the patient is okay. And that's it for this procedure.